In this lecture, I'll be covering pneumonia. Here are the learning objectives, along with the recommended reading. So here are some fast facts to get us started. First, pneumonia is the most common infectious cause of death worldwide. It peaks in the winter months. And pneumonia and other infections can cause toxic metabolic encephalopathy. So it is not uncommon for an elderly patient to be encephalopathic due to pneumonia, and a third of those can have persistent symptoms. And finally, documentation-wise, pneumonia is just not good enough. You need to specify exactly what type of pneumonia it is, which I'll talk about in the next few slides. There are several ways to classify pneumonia. One of these is where is it at in the lung? Such as, here is a chest x-ray of a patient with left-sided lobar pneumonia. It's called lobar because it's only affecting one lobe. This is a patient with bronchial or bronchopneumonia. It involves the central bronchi and it's patchy, typically bilateral and asymmetrical. It's usually associated with parabronchial cuffing, which is basically when you get bronchial wall thickening due to excess fluid or mucus that causes these patches of atelectasis. Here's a patient with interstitial pneumonia. As you can see, it involves the interstitial space. It's also what we call ground glass appearance, which is very commonly seen in COVID patients. It's bilateral, and as opposed to the previous x-ray, this one is more symmetrical. And here's a necrotizing pneumonia. This patient probably has TB with a cavitary lesion with internal air fluid levels suggesting lung abscess. You can also see a right-sided hydropneumothorax with leftward shift. Another way to classify pneumonia is by what the underlying cause is, such as aspiration pneumonia, or a specific bug, such as pneumococcal or atypical pneumonia. Oftentimes, you may not be able to confirm this at the beginning, so this is a diagnosis that you make later on in their hospital course. The final way, and the most commonly used, is by how it is acquired, such as CAP versus HAP versus VAP. That's community-acquired versus hospital-associated versus ventilator-associated pneumonia. So as far as some definitions go, community-acquired pneumonia means that you got it from the community around you, and this is the most common type. Hospital-acquired pneumonia is pneumonia found greater than 48 hours after admission and indicates that the patient has heightened risk of MRSA and Pseudomonas, whereas ventilator-associated pneumonia is pneumonia found greater than 48 hours after intubation, which I will talk about later. So healthcare-associated pneumonia is another definition that reflects the 2005 IDSA guidelines and includes patients hospitalized greater than 48 hours in the past 90 days, residents of nursing homes, patients on hemodialysis, and patients who received IV antibiotics, chemo, wound care in the past 30 days. However, in 2016, new IDSA guidelines were released and basically got rid of this type of pneumonia, so it is not used anymore. Basically, they discovered that through multiple studies that these patients really don't have increased risk of multi-drug resistant organisms like it was previously thought. Another definition you should be aware of is aspiration pneumonia. This is another type of pneumonia, which is when anything but air enters the lungs, such as food, stomach acid, blood, vomit, anything else. The causes of community-acquired pneumonia can be divided into typical, atypical bacteria, and viral causes. Typical bacteria include things such as Strep pneumoniae, also known as pneumococcal pneumonia, Haemophilus influenza, Moraxella catarrhalis, and Staph aureus. These are the same bugs that also cause sinusitis, so you can remember that for your boards. Atypical bacteria refers to the intrinsic resistance of these organisms to beta-lactams and their ability to be visualized on gram stain or cultured using traditional techniques. The primary atypical bacteria is Mycoplasma pneumonia, which causes up to 30% of community-acquired pneumonia. Viral causes can include influenza, rhinovirus, parainfluenza, RSV, and newly added COVID-19. Your workup and write-up for community-acquired pneumonia should include a few scoring systems if possible. These would include the PSI, or Pneumonia Severity Index, and the CURB-65 score. The Pneumonia Severity Index has greater sensitivity, around 90%, so it is considered better. However, it is more difficult to calculate. Whereas the CURB-65 is simpler and not as accurate, but is still commonly used to predict mortality and help you determine if a patient should be admitted to the hospital. Now on to further workup. The physical exam is not sufficient to confirm pneumonia and only has a sensitivity around 50% and specificity around 70%. Chest X-ray findings don't necessarily distinguish the cause, but should be used as a piece of the puzzle when evaluating pneumonia. Blood and sputum cultures need to be obtained. Get them before antibiotics are given, if at all possible. However, these only identify the cause of community-acquired pneumonia in less than 6% of patients. And you should obtain urine antigen tests such as strep pneumoniae and Legionella. These should be obtained and are usually reserved for severe cases. The management of community-acquired pneumonia depends on whether you're treating the patient outpatient or inpatient. If they're outpatient without any risk factors, typically a macrolide such as azithromycin or doxycycline is sufficient. However, if they have chronic comorbidities, or if you live in an area with macrolide resistance to strep pneumoniae, you may consider a respiratory fluoroquinolone, such as moxifloxacin or levofloxacin, plus a macrolide, like azithromycin. So for instance, amoxicillin plus azithromycin should be more than sufficient. However, if you're treating the patient inpatient, one key treatment is early mobilization, which is proven to decrease the length of stay. And then as far as antibiotics go, you should add a respiratory fluoroquinolone, as mentioned, like moxifloxacin or Levaquin, or a beta-lactam, such as Rocephin, plus a macrolide, such as azithromycin. If there's concern for Pseudomonas, say the patient has a previous culture with Pseudomonas, or if they've got concomitant COPD that's severe, you may consider covering for Pseudomonas with either cefepime or Zosyn. If they have concern for MRSA, you would add IV vancomycin. The treatment duration for community-acquired pneumonia is typically 5 days or until the patient is clinically stable and that's capitalized, and afebrile for 2 to 3 days. Longer treatment, typically 2 weeks, is indicated if the patient has infection with MRSA or Pseudomonas. Other treatments to consider are steroids. This is reserved for patients with severe community-acquired pneumonia and has been proven to decrease mortality. Other consideration is cough medications with plus or minus benefits. Honestly, you have to outweigh the benefit versus the risk with these, as you want the patient to cough up as much sputum as possible to help their lungs. However, if they're miserable and they're not sleeping at night, then it may be beneficial to add some cough medicine. Vitamin C is another newer treatment that's been shown to decrease the duration and severity. You can also add percussion therapy, which is the vest they put on their chest, shakes their chest really hard and can help their cough become more productive. There's a lighter version of this, which is a mucus clearance device, which is a little flutter valve that makes them cough harder. Another treatment could be Tamiflu if they have underlying influenza. And you should always consider giving them their flu and pneumococcal vaccinations during their hospital stay or after their clinical picture has improved. Some complications from community-acquired pneumonia include understanding that a chest x-ray will take up to 12 weeks to clear, especially in the elderly. So patients need to be aware of that even though the pneumonia is still present on their imaging, it's going to take up to 3 months for that to actually resolve. So if they get a repeat chest x-ray in the next month, it's important that they warn their primary care physician or whoever's taking care of them that they were recently treated in the hospital for this. Another complication is pneumonic effusion, which can develop in 20 to 57% of patients. Sometimes this will contribute to their hypoxia, and then they'll need a thoracentesis to further drain their lung to help them feel better. This is also nice because you can actually do cultures on them to help isolate the bug. So 40% of pneumonic effusions end up becoming empyema, which is an important complication and typically needs cardiothoracic consultation to see if they warrant any surgical treatment for it. Another complication is sepsis. A lot of times patients with community-acquired pneumonia admitted to the hospital will meet septic criteria. So they'll have positive SIRS or positive SOFA along with the source of infection. Another is cardiac complications. This could include heart failure, arrhythmias, or MI. And oftentimes I wonder down the road if we'll be starting aspirin following pneumonia or other infections in the future. As you know, infection equals inflammation, which equals a hypercoagulable state. So I could personally see it in the future where we're starting all community-acquired pneumonia patients on aspirin. However, that's not the current indication. So here are some bug-specific signs and symptoms. So strep pneumoniae typically produces a rust-colored sputum, whereas Pseudomonas, Haemophilus, and pneumococcal causes more of a green sputum, and anaerobes cause a foul-smelling, bad-tasting sputum. Legionella is associated with watery diarrhea, altered mental status, bradycardia, and lab abnormalities. Remember this for your boards because you may have a patient that presents with watery diarrhea and pneumonia. You should automatically think of Legionella. Also, most bacteria or most bacterial infections and sepsis will actually cause tachycardia, whereas Legionella causes bradycardia, so that's an important distinguishing factor. The lab abnormalities commonly associated with Legionella include elevated LFTs, hyponatremia, hypophosphatemia, and elevated CK level. Legionella and mycoplasma are usually increased when it's humid. So when it's hot and humid during the spring and summer months, this is when you'll typically see an uptick in these infections. MRSA is rare to cause community-acquired pneumonia, but it's still worth mentioning. It causes cavitary infiltrates or necrosis, and it can rapidly progress to, or you can have a rapidly increasing pleural effusion. Also with MRSA, you can see gross hemoptysis. Oftentimes you can see this concurrent with influenza infection. So even though you're admitting a patient with influenza pneumoniae, you may think that you don't have to start them on antibiotics. However, oftentimes we do just in case they have a secondary bacterial component. Also with MRSA, you can see neutropenia, and it's worth mentioning that most COVID patients also have neutropenia. With MRSA, you can also see an erythematous rash or skin pustules, and you typically have severe pneumonia during the summer months associated with MRSA. So when should you worry about MRSA as a cause for community-acquired pneumonia? Probably never. It actually makes up only less than 2% of community-acquired pneumonia, yet 30% of patients end up on vancomycin because of worries about it. So you should only cover if the patient has a history of MRSA infection or if the patient's received IV antibiotics within 30 days. So this kind of goes back to that HCAP definition. So technically HCAP has gone away. However, let's say the patient was admitted or in a nursing home or even outpatient, but they got a dose of Rocephin in the ER. Technically, if they've gotten that within 30 days, then they meet criteria where you should consider a drug-resistant organism like MRSA. A negative MRSA-NARI screen is around 100% effective in ruling out MRSA pneumonia. So most patients, if you do start them on vancomycin on admission, it's imperative to get a MRSA PCR screen on admission, which takes a day to come back usually. But then by then, if it comes back negative, then you know that you can de-escalate and take them off the vancomycin. So as mentioned, hospital-acquired pneumonia is pneumonia greater than 48 hours after hospitalization. Oftentimes these patients can have septic shock, and they may even require ventilator support. Remember, this does include patients who have received IV antibiotics in the last 90 days. Or if they have underlying bronchiectasis, then they're at high risk for hospital-acquired pneumonia. Also, if they've had Pseudomonas with greater than 10% resistance to potential monotherapy in the past, you should treat them as hospital-associated pneumonia. The etiology for HAP includes bacterial, such as the KES organisms. MRSA is also high, greater than 50% in the U.S. is MRSA. Also need to consider Pseudomonas and Legionella. You should consider fungal causes in immunocompromised patients or patients that are chronically on chemotherapy or immunosuppressants like steroids. And viral, these are the same organisms as community-acquired pneumonia. As far as antibiotics go for healthcare-associated pneumonia, you need to determine their PSI score to decide if they're low or high risk. If they have a low mortality risk, typically a single agent targeting MSSA, Pseudomonas, and gram-negatives will suffice. Typically, this is done with either Zosyn, Cefepime, Levaquin, Imipenem, or Meropenem. If they have risk factors for MRSA, then you need to add Vanc or linezolid. However, if they have high mortality risk on the PSI score, then you need to consider two agents targeting the same bugs as above. You would typically do a beta-lactam or beta-lactam-like antibiotics such as Zosyn, Cefepime, Imipenem, or Meropenem, and you may need to do aztreonam also. You'd also add a non-beta-lactam such as Levaquin or an aminoglycoside like tobramycin or amikacin. And if they have risk factors for MRSA, you would add Vanc or linezolid. Now, it's important to understand that there are only certain drugs that actually cover Pseudomonas. So I've included that list here, and you should have a pretty good understanding of these antibiotics because you'll need this for your clinical rotations. The duration of therapy for healthcare-associated pneumonia is 7 days for most patients. Honestly, I don't really know how they came up with 5, 7, 10 days. I really don't know. I think, if we had, 8 fingers on each hand, they would probably say 8 days would be the therapy of choice, but this is what they've come up with. So I'm only going to talk briefly about ventilator-associated pneumonia. With this, the differences from healthcare-associated pneumonia and ventilator-associated pneumonia is very thin. And really, you just have to understand what the resistance patterns are in the hospital that you're working at. If the patient has 10 to 20% MRSA in their hospital, then you know that you need MRSA coverage. If the patient or if the hospital or if the area has greater than 10% pseudomonal resistance, then you need to determine whether one anti-pseudomonal antimicrobial is okay or if you need to add 2. And finally, I'll talk about aspiration pneumonia. As you can see from this chest x-ray, this patient has a consolidation in the gravity-dependent right lower lobe of the lung. So risk factors for aspiration pneumonia include altered mental status, such as if they come in as an alcohol or drug overdose and they're altered and then they become hypoxic, you should always consider whether they've aspirated or not. Even if their chest x-ray is negative, it may take some time for that to show up on imaging, so you should probably treat them just in case. Also, if they have underlying neurologic disease, such as if they had a stroke and then they become hypoxic, or they're having shortness of breath and productive cough following a stroke or seizure, or even head trauma, you should highly consider whether they've got aspiration pneumonia. Also, if they've undergone anesthesia, if they're just getting out of surgery and they call you for a consult and the patient's hypoxic, you should consider whether they aspirated. Also, if they have anatomic abnormalities such as esophageal stricture, achalasia, if they've got underlying GERD, or if they've had an ET tube feeds. So the etiology of aspiration pneumonia has to come either from the mouth or the stomach. So the treatment is the same as with community-acquired pneumonia. However, you also need to cover for Enterobacteriaceae, otherwise E. coli or other gram-negative rods, along with anaerobes. Anaerobes are what you should always consider with aspiration pneumonia. They're highly overrated, but you still have to treat for them. So if it's above the diaphragm, you think more gram-positives, such as Actinomyces, Peptococcus, and Peptostreptococcus. Whereas if it's below the diaphragm, these are more gram-negatives like Clostridium and Bacteroides. Either way, these are all anaerobes and you need to treat for anaerobic coverage. They only make up a small percent of aspiration. However, like I said, you always treat for anaerobes when you suspect aspiration pneumonia. Anaerobes from the mouth are typically strep-based, so beta-lactams are fine. However, it's really difficult to convince any physician, even pulmonologist, to treat otherwise. It's important to understand that most aspirations are actually chemical or aspiration pneumonitis. So if you vomit up acid from your stomach, it's typically something like that, and it may not even have very much bacteria in it, but most of the time you'll still see that people treat for anaerobes. So there is no clear-cut treatment that is best for aspiration pneumonia. The antibiotic choice is based on concern for that anaerobic infection, like I had talked about. If the patient has community-acquired pneumonia with aspiration, the options include clindamycin, which I rarely see used just because of its toxic effects, or a beta-lactam plus a beta-lactamase inhibitor such as Augmentin, which is oral, or Unicin, which is IV, or you can use moxifloxacin to treat those anaerobes. For hospital-associated pneumonia with aspiration, the options would be to cover for anaerobes with either Zosyn or meropenem, and the treatment duration overall for aspiration pneumonia is 7 to 10 days. So just to review, let's say this is a 75-year-old male who presents to the ED with shortness of breath, productive cough, and hypoxia requiring 2 liters. Here's the chest x-ray. So what do you think of this? So honestly, looking at that chest x-ray, I would worry that this patient may have aspiration pneumonia. So I would make sure to ask them about any aspiration symptoms. Did they choke or cough when they ate, or did they have any recent nausea and vomiting, anything like that would make me suspicious of aspiration. You need to make sure that they haven't had any IV antibiotics within the last 90 days, concerning to make you think that they might have healthcare or hospital-associated pneumonia. Do they have any history of Pseudomonas or bronchiectasis, which would indicate broadening the antibiotic coverage for their Pseudomonas? So diagnosis, it's not pneumonia. Remember, you need to further define it. So you can call it aspiration, community-acquired pneumonia, hospital-associated pneumonia, whether they've got questionable underlying COPD on top of it. If the patient wasn't on 2 liters nasal cannula before, you could call this acute hypoxic respiratory failure secondary to community-acquired pneumonia with risk for aspiration pneumonia. You can make that diagnosis as long as you need to, as long as you put the clinical picture of what you think is going on in your note. So further workup for this patient, I would highly consider getting a speech therapy eval. I would get blood and sputum cultures. I'd get a procalcitonin. I'd probably get a MRSA PCR, especially if I had any concerns or was starting the patient on vancomycin. I would probably get an echocardiogram along with a BNP on this patient if they haven't had one recently, just to see if they have an underlying element of heart failure. As you can see, I mean, this patient may, it looks a little cloudy there, so this patient could have some underlying heart failure going on. So treatment for this patient, obviously if I was worried about aspiration pneumonia, I would need to cover for anaerobes. So I'd probably add like Zosyn. If I was worried about hospital-associated pneumonia, I would probably add vancomycin on top of that. Remember, with the anaerobic coverage, I said Zosyn, and that would also cover for Pseudomonas if I thought the patient had underlying COPD on top of that. I'd probably add nebulizers also. I would avoid inhaled corticosteroids, but if the patient became severe, I might add systemic steroids. I'd probably add mucolytics on the patient, maybe some Mucinex scheduled. I'd probably get like pulmonary rehab to see the patient, and I'd make sure that we ambulated them as quickly as possible to decrease their length of stay. I'd probably add incentive spirometer and or a flutter valve on top of that just to help prevent any further atelectasis and to help their cough be more productive while they're in the hospital. And with that, we've wrapped up pneumonia. So if you guys have any questions, please post them on the Google document, and here are my sources for this lecture.